Anyway, we're going to talk about child maltreatment and brain consequences, and then the clinical relevance of this. And we can talk about all sorts of scientific stuff, but what does it mean for practice? How does it affect us as clinicians? Where do we put this into play? So, again, we think about, we know that child abuse happens. We know that abuse to a lot of people happens in a lot of different formats, but why is it that we see consequences from this? In my practice, I started recognizing that people presented because of their experiences of abuse many, many years ago, back when I was in private practice in Chanhassen, started in 1980, and started to listen to these stories day after day after day, and I can tell you that now I've heard well over 2,000 stories from that practice and from emergency medicine of people who have had bad experience in their lives that contribute to why they present to us. And it's always been, how come this is? Why does it turn out this way? Why does it affect the body the way it does? And how many of you have ever seen a patient who says, why can't anyone figure out why I feel this way? And we see these people in the emergency room pretty frequently, that they say they've been to umpteen doctors and nobody can figure anything out. I've had test after test or repeated tests and still don't figure anything out. And these are the ones that they're very challenging patients, and I kind of enjoy getting involved with them because sometimes I can help them see the light. Again, I first recognized these patterns in practice setting many, many years ago. And the key is that life experiences, and it doesn't have to be one particular kind of experience, but life experiences in general just do contribute to how people feel and consequently the medical presentations to us. And the range of experiences is extremely broad. The way I tend to talk to patients, I don't try to focus in on one particular kind of experience. I just let them open up and tell me what's happened in their lives that may affect why they feel the way they feel. Well, one of the things we recognize is that we have many patients who do have abuse histories. And in fact, we know that if you look at the population in general, probably somewhere between 25 and 40 to 50% of the population has experienced some type of violence and abuse in their lifetime. Now, it may be minor, it may be real severe, it may be over a long period of time, it may be a single event, but a significant number of the population really has experienced bad things in their life. And we know that that contributes to the increased frequency that people present to us. So we see a lot of patients who do have abuse histories. We also know that many of our patients are frustrating to us. They're difficult to diagnose. We're trying to figure, we say, this just doesn't fit something that's in the book. I can't quite know what's going on here. Let's try this, try this. They're difficult to treat. We give them one drug, or we give them another drug, or we send them off for physical therapy, whatever we do. And they keep coming back, and they say, I'm not any better, I'm not any better, and I'm not any better. They're frustrating to treat. And they're very difficult to convince to change. We know that there are lifestyle, behavioral sorts of things that people engage in that we think, gee, if they would just change this, they'd feel better. But we can't get them to change. Or we say we're going to do something, if they don't change, they say, give me another chance, doc, I'll do it. But then they're afraid to come back because they don't want to be embarrassed they really haven't changed. And many patients are frustrated. Again, they come into us. They've seen 4 or 5 other doctors. They're frustrated that nobody has gotten an answer for them. Why do I still feel this way? And lo and behold, it seems to me that many times these are all one and the same patient. History of abuse, difficult to work with, frustrated. There are patients. Now, this is my perception. Is it true, or is it just my perception? Well, I started looking for some evidence to see. And I've been going to the internet over and over for many, many years. And in fact, there's a ton of stuff out there. And I know you can't read this, but I'll just tell you, just this first one on this internet search is the relationship of childhood physical and sexual abuse to adult illness behavior. There are a lot of articles like this in the literature that support the concept that bad lifetime experiences contribute to adult illness problems. Literally hundreds and hundreds and hundreds of articles out there on this, but very few of those articles make it into the medical literature. Oops. Anecdotes. Again, I tell you that I've heard over 2,000 stories in my practice. And having heard that many stories really gives me, I don't know if it's wisdom, but at least it's the knowledge, it's the understanding about the patterns of how people present. So that it's pretty easy for me when I start to talk to somebody or I look at them and I kind of hear those same things, and it's just a gut sense. I know that there's something there that I can go back to and probably find that's contributing. then the clinical research. So we've had some of this evidence that there is this background, and so we've started to go into the clinics and say, okay, let's see if we can actually find it and see and make these correlations. And the correlations are there. Again, the research over and over and over again supports that this is not just perception, it's in fact the case. And now the new scientific information that I'm about to show you begins to tell us why some of this happens. Just to review a little bit of Vince Felitti, and some of you, if you've been here before, listening to me, have heard about Vince Felitti. He's an internist in the San Diego area, though he's pretty much retired now, but for years he was working in the Kaiser Permanente adult health screening clinic. And he began to notice some of these same sorts of patterns, and he got together with Robert Anda from the Centers for Disease Control, and they put together a study that now has, well, most of their research that they publish is based on about 17,000 or 18,000 patients that they've drawn data from, but in fact they probably included over 30,000 patients in all the years that they've been doing this study. But their work really has been to look at lifetime experiences in childhood and see how it relates to adult health behavior or presentation. And this is just kind of a very quick summary. You don't have to read all these. Just look at the graphs. They all look like this. And what these graphs are basically relating adverse childhood experiences to adult presentations, risk behavior, experiences, and so on. Now, ACEs, the Adverse Childhood Experience, ACE, include things like, well, you'll see in just a second, it'll include things like bad things happening in the home, like divorce and separation, people being in jail, people who are involved in drug use, sexual abuse, emotional abuse, neglect, physical abuse, domestic violence, all those, mental health illness, and so on in the family. So all of these exposures contribute to high-risk behavior. One of the interesting things to me is, if we look at rape, if there are no adverse childhood experiences, the odds ratio down here, about 5% chance of being raped as an adult. Just experiencing one adverse childhood experience doubles your risk of being raped as an adult. Having two adverse childhood experiences more than triples your risk of being raped as an adult. So, and that's what all these graphs have to do with in terms of smoking behavior, use of alcohol, drugs, promiscuity, and then of course that leads on to, all of those behaviors lead on to all the health problems that we see. So, then we came up with a concept called CALIVA. And some of you have seen this before as well. CALIVA standing for Consequences of Lifetime Experiences of Violence and Abuse. And basically it was an attempt to try to put this together pictorially so that we can show exactly how much impact this has on health and healthcare system. So this is, again, don't try to read it because I can't even read it up close. But we didn't make copies of that, did we? Denise? Or we didn't make copies of that, okay. If you want a copy of this, it's available in many places. It's available on our website, by the way, but we can make copies for you. And the idea here is basically that you can take almost any category in healthcare in terms of body system or area of interest in terms of healthcare, from dermatology and neurology and dental care, GU, neurology, let's see, ophthalmology, orthopedics, cardiovascular, OBGYN, and begin to see all the ways that people present as a result, or at least there's a strong correlation to. We can't really say causative yet, although we can come pretty close, but at least very, very high correlation with these health presentations as a result of lifetime experiences. So it's very broad. It really involves the entire medical community. It doesn't make any difference what specialty you're in. It's going to be there. Like Bruce Fossey, we know that people who've had bad lifetime experiences are going to have a much higher rate of surgical procedures. People are going to complain more. They tend to push more for surgical procedures. And there are many stories that people have had. The person that comes in has had 23 different operations in their life probably has a bad history. Even if you can say, well, they needed all those 23 operations, nevertheless, there's usually a history behind it. So why does this happen? Well, we came up with the concept, does the brain actually change. There's something happened in the brain that leaves a scar as a result of this. And in fact, the current literature talks about the anatomy of the brain. And if we look at the brain as something that's rich and promising and wonderful at birth, and then we expose that brain to all these sorts of things, this is what happens. The brain changes. Cool. Anyway, so again, somebody who's incarcerated in the home, mental illness, substance abuse, neglect, sexual abuse, physical abuse, mother abused, separation, divorce, emotional abuse, and so on. When a child is exposed to this type of environment, the brain actually does change anatomically, chemically. The areas of the brain that are affected: the limbic system, hypothalamic, pituitary, adrenal axis, corpus callosum, cerebellar vermis, prefrontal cortex, ventricles, brainstem, temporal lobe. You don't really have to memorize all this stuff. What I want you to get is the general sense that the brain, a lot of the brain is affected by these sorts of adverse behaviors. The limbic system is sort of the system that is responsible for emotions and memory, a lot of other some basic sorts of things. We're going to focus on the pituitary gland, hypothalamus, amygdala, and hippocampus. And again, you know, you don't have to really remember all the anatomic stuff. I'm not going to take you back to medical school or nursing school or wherever to try to remember this, but just to understand that these are changes and why these changes have an effect. So let's talk about a couple of the structures in the brain. The hippocampus is involved in memories, developing, maintaining memories, emotions, spatial orientation. Corpus callosum is really just the white matter connections between the hemispheres. So that link between the right and left hemisphere, where all the connections are going back and forth, the corpus callosum is that white matter that connects between there. Lateral ventricles, those are just empty spaces with fluid. The cerebellar vermis is back in the middle of the cerebellum, and it controls muscle tone and coordination. And it actually has some other tasks too, but these are the ones that make me think. The cerebellar vermis is what looks at what the brain wants to do, what instructions you're giving your body, and compares it to the feedback of what, in fact, the body did. I want to put my leg here. Did, in fact, I put my leg there? And the cerebellar vermis is what compares that and says, yes, it was the right thing, or compensates for that so it does the right thing. So when the cerebellar vermis is affected, you can think about people that have more trouble with maybe dizziness, balance, shakiness, tremors, and things like that. And some of those sort of motor types of abnormalities may come from changes in the cerebellar vermis. And the amygdala, which is involved in arousal, fear, and aggression. So this is what happens. The hippocampus gets smaller. Corpus callosum is smaller. In fact, this is very significant, that white matter connection between the two sides of the brain. In adults who've grown up in adverse environments as children, corpus callosum is smaller. Now, why should that be? There's less connection between the two sides of the brain, less synapses. Cerebellar vermis, that deals with that coordination and stuff, that is smaller. The amygdala is smaller. Putamen is bigger, lateral ventricles are bigger. We don't have to go into all of that. But these are all changes that have been measured over and over and over again. Briefly talk about kind of the cascade of what happens in the brain when the body is threatened. And this is really a very basic function of all animals. So this really was built into the animal system long, long ago. When the organism feels a threat, physical or psychological threat, the very first area that becomes involved is the locus coeruleus. It's down deep in the sort of the primitive part of the brain, and stimulates the sympathetic nervous system, and you get an outpouring of norepinephrine and serotonin and dopamine that sends these signals into the rest of the brain. And what happens, first of all, is the hypothalamus says, okay, we got stimulated to make CRF. CRF is corticotropin releasing factor, a hormone that then is sent to the anterior pituitary gland. Again, don't have to memorize all this, but just kind of watch this cascade and see how it plays out. So CRF, corticotropin releasing factor, says to the pituitary, we got to make steroids. So ACTH, adrenocorticotropin hormone, is released by the pituitary, sent down to the adrenal gland, so it'll start to make more glucocorticoids. And in the in the human being, mammalian humans, it's cortisol is the glucocorticoid that is stimulated. And this is sort of one of those stress hormones. When there's stress, our cortisol levels start to go up, and we know that because we're supposed to give extra cortisone or whatever when somebody comes in. If they're have adrenal insufficiency or been on steroids for a long time, we need to give them that boost when they have stressful events going on, surgery and infections and so on. Well, this is what the body's supposed to do. But in a normal situation, the cortisol goes up, but it goes up transiently. It goes up and then sends back signals, an inhibitory cycle that goes back and tells the pituitary and the hypothalamus, okay, turn it off. We went up, we responded to the stress, but now turn us back off. And this is the axis that's supposed to work. And also there's a signal sent up to the hippocampus. But what happens when a child grows up in an environment where in fact the threat is continuous and repeated? Well, what happens is then that CRF is chronically stimulated, corticotropic releasing hormone, and cortisol remains high. It never gets the cycle back where it shuts off and turns off. And what happens with this is it sort of blunts this whole system. It doesn't work very well. So everything kind of gets out of balance. And when things are out of balance, the brain doesn't grow the same way. This is very important understanding about why this all happens. Let's talk about what happens when the brain is exposed to elevated glucocorticoids over a prolonged period of time. Well, it turns out that the glucocorticoids inhibit myelination. You might say, so what? What does that mean? Well, myelination is really the maturation of the nerves in the brain. As the brain grows up, the nerves are becoming myelated and insulated and sort of fixed in whatever state they're going to be. Well, when there's high glucocorticoids, you inhibit the myelination, and they don't mature then at the time that they're supposed to be maturing. Delayed maturation of the brain structures, reduced synaptic connections and dendritic proliferation, and it affects the pruning of the neurons. Again, when we're born, we have an excess of neurons and potential synapses, and there's pruning in our brains no matter what as we grow up. But when we are exposed to adverse environments, that changes the way that pruning occurs. So the connections that end up in the brain are different than the connections in the brain in people who haven't experienced the high stress. So it's going to be some repetitive stuff here, but this is just from the winter of 2006. This is an article that came out that sort of summarized some of these things that we found. Increased electrophysiological abnormalities in the left frontotemporal region, higher prevalence of ictal temporal lobe epilepsy-like symptoms. And this is something I think is really interesting as well, that in fact, temporal lobe epileptic findings on EEG are much, much higher in people who have a childhood adverse experiences than people who did not. And it's a very strong correlation. Abnormally elevated left hemisphere EEG coherence. I was hoping a neurologist might be here could tell me what that means. It was one of the things listed, but honestly, I don't know what EEG coherence means. Anybody here have a clue? Yeah, forget it. Reduced volume of the left hippocampus. The hippocampus, again, has to do with memories, emotions, and so on. And what's interesting is that depending upon the time of life that you measure this, the hippocampus can be bigger or smaller than average, depending, based on experience of adverse childhood events. But as an adult, we're generally left with smaller hippocampus. Again, what does smaller mean? I don't know. Does it mean it doesn't function as well? Does it respond differently? But just from a size standpoint, it's significantly different. Smaller corpus callosum we talked about, alterations of cerebellar vermis, abnormalities, and all the rest of stuff. Hormones that are affected. A lot of hormones are affected. We talked about the hypothalamic pituitary adrenal axis. Corticotropin releasing factor we talked about as involving, its responsibility is to then tell the pituitary gland to release ACTH. But in fact, it turns out that CRF comes in various different forms, different colors, different whatever you want to call them, and they have actually more responsibility than just that. Here are some of the other things that CRF does. It's involved in the arousal and CNS activation. It's involved in anxiogenesis, in other words, creating sort of the anxiety reaction in the body. It's involved in appetite suppression. Think eating disorder. It's involved in GI motility and gastric emptying. Think irritable bowel syndrome. It's involved in vasodilation. Think about lightheadedness, fainting spells, so on. It's involved in uterine contractions. Think about PMS and pelvic pain. Think about in cardiac inotropism. Think about the palpitations, panicky sorts of symptoms. So CRF plays a role in all of these different areas. AVP we won't talk about. That's arginine vasopressin. ACTH we talked about, glucocorticoids. Serotonin and other neurotransmitters are affected. Substance P, which is a neuropeptide involved in pain response. And we know that people who have had adverse experiences in their life tend to have higher levels of substance P in their intestines. It's higher in people who have irritable bowel syndrome. Substance P is higher in the spinal fluid. It's higher in people with chronic pain syndromes. And they've been able to duplicate this. The substance P actually mediates the pain response, and they've injected it into spinal fluids of experimental animals and things, and then looked at how they respond to noxious stimuli and so on. And it starts to make sense why people who've had bad experiences in childhood then tend to react to pain differently in adulthood. And these people come in and we think, you're saying this pain is an 8 out of 10, and it doesn't look like it to me. But in fact, that's the way it feels to them. And it may be because their substance P is a lot higher. And then the noradrenergic receptors. Chronic stress and dopamine. Again, this is one of the neurosubstances that is affected by the chronic stress. We have overproduction of dopamine in our brains when we're experiencing continued and repetitive stressful events. That leads to reduced attention. Again, think about things like ADD and so on. Increased overall vigilance, this hypervigilance that we sometimes see in people. It's just like, okay, I don't know where things are coming from, and ooh, that bothers me, and oh, don't do that, and don't give me that drug because I don't like the side effects. There's a hypervigilance in the body that happens because of the overproduction of dopamine. The reduced capacity to learn new material. Again, the impact of this, the ripple effect is pretty wide. It's hard to learn new material. Does that mean that they have learning difficulties in school? Is it hard for us to get through to them and get them to understand what's going on? There's increased paranoia and psychotic behavior. Serotonin. Serotonin stimulates both anxiogenic and anxiolytic pathways. So it has multiple different effects. I'm not sure how that exactly plays out, but we know that it does do so. And when you have an effect on the serotonin, and particularly in this case, we see decreased levels in the prefrontal cortex. Now, serotonin has to play a role. The prefrontal cortex is an area which helps to deal with executive function, decision making, good judgment, all that kind of stuff. And so now, if you've got abnormal hormonal levels in your prefrontal cortex, is that going to affect your judgment? Why you make certain decisions in your life? Why you do certain types of risk-taking behaviors? Or we can't get you to understand why you should be doing something differently than what you're doing. You just don't have the capacity, perhaps, to that good executive function. And we see suicidal behavior, depression, and aggression with the serotonin effects of chronic stress. The amygdala. To move on to another structure in the body. The high stress and the high glucocorticoids results in deficits in oxytocin. Now, if you have low levels of oxytocin throughout your life, what that's been related to is early menopause. Of course, early menopause then is going to put you at higher risk for early heart disease and so on. So you start to see some of the other healthcare implications of changes in the hormones in the brain. And the other thing that we see is when you have low oxytocin in the brain, we start to see sexual aggression, dissatisfaction in general, intimate partner violence is higher, impaired pair bonding is measured, and so on. So a number of other, again, behavioral sorts of things, unhealthy types of personality disorder kinds of stuff. So, in fact, Vince Felitti, as I mentioned before, talked about all these different factors that happen in childhood and the results, and he wrote an article about how we end up changing gold into lead. And it's kind of an interesting concept that we take the rich, wonderful brain, and by doing bad things to it, we've turned it into this lump of lead that doesn't function very well anymore. But one of the key things, I think, again, to remember again, I've used this slide several times, but I want to reinforce it, is that we need to understand this mechanism because we need to understand that our patients then tend to respond to pain differently. Their pain response tends to be exaggerated because of their lifetime experiences, and that this is not a choice that they make. And this is something that's hard for many of us to grasp, as we see these patients that come in and we think, why are they still complaining about this? Why don't they ever get better? Why do they keep wanting to, to do all this? And to realize this really isn't the choice that they're making. It's what's happened to their brain that's put them at risk for this. And our professional response needs to reflect that understanding. We need to be compassionate, understanding, and tell them, I understand why you're feeling this way, and there's a reason for it. So the clinical consequences, there are many things that we see. Some of the list of things: chronic fatigue syndrome, PTSD and panic disorders, depression, suicidality, addictive behavior, eating disorders, fibromyalgia, chronic pain syndromes, dissociative disorders. Schizophrenia, I didn't think was going to be on the list, but in fact, in the last year, there's literature that suggests that, in fact, it is related to this. Rheumatoid arthritis, and you might say, wait a minute, how can that be related to this? But in fact, we've now shown that because of the effect on the immune system, because of the glucocorticoids and so on, it actually does affect the way the immune system is built as well, and rheumatoid arthritis tends to be seen at a higher rate in people who have early childhood abuse issues. And asthma is also in the picture. And I didn't think those things would show up, but in fact they are starting to show up. So we do all of this. Can we do something about it? So we may be understanding it, we might accept it, but then what do we do? Well, some interesting findings. When we look at people who do have these changes in their brain, when we've measured that in fact their brain structures are smaller, bigger, and the hormones are all different, and which is really fascinating to do because of all the new MRI techniques that they can practically literally measure the levels of certain chemicals in there. We do find that SSRIs do tend to normalize ACTH and cortisol. So when people say, gee, I don't want to take a drug, I don't want to feel like I'm dependent on an antidepressant, it doesn't make me feel good to think I need to take this medicine, you can tell them it's not just it's not just happy pills. It actually really does help to normalize the abnormal brain chemistry in terms of the ACTH and cortisol, those stress response sorts of things. Dilantin has been shown to be effective in some of these cases where there are the brain changes going on. Propranolol has been shown to play a role in terms of memory of bad events. And we know there's a certain cascade of things that happens in the brain where there's really, some things in your life you remember really, really well, and you can remember every detail about them, and other things are just vague clouds of things. Well, some of the hormones in the brain contribute to that. When there are very stressful events, there's a certain set of things that help to sort of cement the very vivid imagery in our brain, and propranolol will help to blunt some of that. So if people are exposed to really nasty experience and are high risk for PTSD kinds of stuff, we know that propranolol may help to prevent PTSD occurrence. Misoprostol, the drug that has been used to protect stomachs and the drug that's been used to induce abortions, also has been shown to have some protective and beneficial effect in brains, the same brains. Ketamine is something that I've been looking at over the past couple of years, the dissociative anesthetic, which seems to help kind of reorganize the brain in some fashion. But we've seen a number of studies coming out that say that you can take people who have these chronic depressions, unresponsive to other treatment methods, and they have the chronic pain syndromes and particularly like the regional pain disorder kinds of things, and you bring them into the hospital and you give them an infusion of ketamine, low-dose ketamine over a period of time, and a very high percentage of these people leave the hospital with resolution of their depression lasting for at least months and sometimes years, and the same with their pain syndromes. And how it actually works in the brain, I'm not sure. I sort of talked about it as a kind of a chemical electroshock therapy in some fashion. But people do have resolution of their symptoms that can last up to a couple of years that it's been measured. It's just amazing. So I think it's kind of a really interesting field to think about. Cognitive behavioral therapy, talking about things, understanding why things happen, has been shown to be extremely effective in people who have the consequences as they grow up. And what has been said in the literature repeatedly is talk, talk, talk. the more you talk, the more cognitive therapy you get, the better off you are, the more likely you are to recover and have sustained benefit by it. So it isn't just drugs, it's a combination of drugs and cognitive behavioral therapy together that gives you the best results. And then this new category that's kind of interesting, the CRF inhibitors. We talked about that corticotropin releasing factor. Well, the pharmaceutical industry is starting to look at, are there some drugs we can use to inhibit CRF? And that's kind of where some of the focus is going to be going here, I think, in the next couple of years. We'll see what happens with that. Okay, so the consequences, we've talked about all these things changing the brain, hormonal, structural, functional consequences in the brain. Interventions, we know that good foster care will help to ameliorate these sorts of effects. Enriched environments where they're focused on very enriched environments, very focused, very much giving good surroundings to people who are experiencing some of these things. And the antidepressants all will play a role in helping to recover from this. But again, you have to have that understanding up front. Translation to practice. This was an article that actually was about schizophrenia and childhood trauma, and actually is where I sort of learned more about the fact that schizophrenia actually is involved with this. But there were some statements in here that I think really are very pertinent outside of just dealing with schizophrenia. The theoretical and clinical implications. And this, again, was just from about a little over a year ago. And what they said was that psychological approaches are more effective than medication for psychotic people who suffered childhood trauma. So it's really important. If childhood trauma is in there, the medication alone is not going to do the best job. You have to have the psychological approaches. And simply making a connection. This is what I have seen many, many, many times in the emergency department. When I sit down with somebody and talk to them about their life history, simply making a connection between their life history and their previously incomprehensible symptoms may have a significant therapeutic effect. And when people ask me in these lectures, they say, well, so what? Does it make a difference? Do people get better when you talk about these things? Well, in fact, people do, once they understand why they're feeling the way they're feeling, because they couldn't make sense of it before. If you can make this link, people start to feel better, start to get, the stress goes down, because it's like, what's wrong with me? Why can't, am I crazy? What's happening? Make this link and they start to feel better. So this was their final statement, and I think you could probably cross off the word mental here, but basically all mental health services should establish policy guidelines for how and when to ask about trauma in general, including child abuse. And again, I'm real happy that in my work here at Ridgeview that I'm able to do some of this work and looking at some of the ways that we try to identify these things, trying to change the way that we ask patients about some of their history. And we're not there yet, but we keep working on it. And there are projects currently going on with the Minnesota Department of Health and many other projects nationally, trying to find out how do we get to this, how do we make this link, and how do we really put it into a comfortable method within healthcare. Prevention issues. I kind of like this little video of these meerkats, looking at danger. And these little guys, I don't know, they look cute. I have no idea if put them in your hand whether they're cute or not. But they tend to look out for each other. And if one is wandering off somewhere and gets into trouble, they tend to all gather around and give them support. For example, if this puff adder comes along and there's one meerkat out there and sees the danger and sort of sends out a signal, and all the others kind of gather around and create, instead of what looked like a little bit of a nemesis there, suddenly you have this big problem for that snake and they run away. So just think about that and how we translate that into how we take care of our own kids as they're growing up. And we don't tend to recognize the danger they're in and all gather around and protect our kids from the danger that's lurking out there. Interesting thing, caution with steroids in early development. We give steroids fairly casually to kids and premature labor sorts of things, and in little kids with the bronchiolitis and all that kind of stuff, we've been tending to give a lot of steroids. Well, in fact, the literature tells us that even a single high dose of steroids early in the brain development may have this effect that we're talking about in terms of high glucocorticoids on the brain. So we have to be a little bit careful about that. Obviously, parent education having people understand why they need to treat their kids in a little different way than what they might have been inclined to do, and the anticipatory guidance component that, again, I think all my life I've believed that it tends to be underutilized, that parents tend to bring their kids in for their well child care, for their shots. They may send them in with the neighbor or the grandmother or somebody else, but in fact, taking the opportunity for these well child checks to use that concept of anticipatory guidance, talk to parents about why it's so important to provide a healthy, nurturing environment for their children so that they'll grow up healthier in body and mind. And basically, I'll stop there. I have lots of other things I can say, but I'll leave it open for questions because usually there are a couple.
Dave, if you go back about 10 slides, you had a list of drugs that perhaps would be beneficial. Sort of the sense I had in your talk was that that's more of an adult treatment. Are any of those drugs applied to the pediatric population when a history of abuse has been identified? Is that any studies on that?
I haven't. The question about whether the drugs that were listed up there in terms of trying to have an impact on this outcome, if that has been shown to be useful in children or what we can do in children rather than just adults. And in fact, I haven't come across any of the literature that talks about that all of this has come from adult manifestation stuff. What we can do to adults that present with the long-term consequences because of this activity. I think that will eventually start to trickle down, but it's not there yet, and obviously it's easier to do the studies on adults than it is on children. I think as we understand more and more about this, there will be a push to start looking at what we can do to children who we take out of some of these environments, and is there something we can do to help remold their brain or to heal the brain before it becomes fully fixed. Well, the interesting is we used to think that the brain was fully developed early, the first 3 years was it, and then whatever was cemented at that point, we're done. But actually, in some areas of the brain, the myelination process goes on until the second or third decade of life. And so we really do still have a chance to have an effect in those sort of transitional years, in the older children age group and the teens and so on that we're seeing with these consequences. There is room for kind of helping to remodel the brain a little bit. So I think we shouldn't think that it's done. We can't do anything at that point. We can. Jonathan, yeah.
There's certainly a huge role in terms of just the awareness and being able to think about these things when we're dealing with individual patients. And then there's the skills we've done the role playing with, just how do you approach asking people about these issues and how that is part of the barrier that we have in terms of getting to some of these issues. Are there some practical, useful tools like the PHQ-9 questionnaire for depression that apply to abuse that helps us to kind of get at some of these issues that are effective? Is that being developed beyond just kind of individually learning some of the skills and interviewing patients?
I've listened to a lot of talks on how to interview patients. I've seen a number of different tools, and there isn't one out there that seems to be great because they all are sort of cookbooky, and I think our patients present to us in so many different ways that it really is, trying to find a way to integrate this discussion into our natural conversation when we get the history of present illness. And just one of the ways that I approach this when I talk to patients is I talk to them about the importance of looking at all of the factors that contribute to why they feel the way they feel. And we look at sort of the assets that they grow up with. What are the good things that they grow up with? What are the bad things they grow up with? Because it changes the way the body works. And it's important for us to kind of identify what experiences they've had and try to say that this really does affect the way the brain and body works. And so then I start talking about the ACEs. I say one of the things that I do is I tend to talk to people about what sorts of experiences had, because we know that this whole category of ACEs has a huge impact on healthcare. And then that includes things like growing up in a family with alcoholism, growing up in a family where there's divorce or separation, where there's somebody who's in jail, somebody who's been identified as mental illness, where parents have been seen as fighting all the time. if people have been physically treated in a way they shouldn't be, if you've felt neglected, if you've been treated sexually in a way that you shouldn't be. Tell me what your experiences have been.
And that's
And
a different approach. I mean, I think the problem that we all have is that we might simply cross that barrier and say, you know, has there been a history of any abuse? Well, a lot of people, I think, don't identify those situations as abusive. It was just the way it was when they were growing up, and that leaves that whole area completely untapped.
right. Well, I think there's a huge lack of understanding in the public, and to respond to the question about how to try to draw this information out in a way that's comfortable for people to acknowledge. And until the public understands why this is important, it's hard for us to sort of get over that barrier and get to where we need to be, get patients to feel comfortable acknowledging what's happened. Now, there's some people who are dealing with their issues and they will just sort of lay it out there for you. But there are many people who have never been there and they don't want to go there, or they may have dealt with it at one time partially and they say, yeah, that was an issue, but I've dealt with it now and I don't want to talk about it anymore. Well, that tells you it's still a problem, because they may have dealt with it in some fashion, but they didn't really deal with it. For example, the woman who I saw who had significant alcohol problems as an adult, and we talked about her childhood experiences that included molestation when she was 4 by a neighbor. But she said she went through a significant amount of counseling to get to the point where she could forgive him. But what she never did was forgive herself, because she basically grew up believing that she had prostituted herself. She was willing to allow him to do what he was doing to her for gum and candy and a dollar bill here and there and things like that. And so she saw herself, as she grew up, as basically allowing herself to be prostituted. Despite the fact that she had sort of worked on forgiving him, she still had this terrible guilt feeling for herself. And I think that was one of the major things that put her at risk for further bad things that happened in her life, and why she was dependent on alcohol, which she said, yeah, as long as I'm in a safe place, I can avoid alcohol, but as soon as I'm out on my own, I'm back to using again. And we talked about how the alcohol is being used as a drug to cover up the pain of her past, and she said, oh yeah, you know, no question about that. But really hadn't ever been approached in that fashion. So it really is, we have to get comfortable with it first. We have to know that it's really an issue, and it's something that we have to talk to people about, or we're not providing full care for our patients. If we don't go there, we're really missing an opportunity to help an awful lot of people. And literally, I can talk to people 3 and 4 times a day still in the emergency department about their lifetime experiences that present to why they come in. Now, it doesn't happen every day. Some days I talk to nobody, but other days I'm talking to 3 or 4 people. And it's always, not always, but most of the time, there's an enlightenment, you know, an understanding that people didn't have before. And I really do think it has an impact on how they change their presentation down the road. So there's a lot of room for improvement on our parts as healthcare providers to understand all of these issues and to find the best way to incorporate it into our discussions with patients. And there's room for just generally improving the public's knowledge that this is a big piece of healthcare as well. All right.